Hello, and welcome to our chat tonight on this crucial topic of the vulvar and vaginal health. This is an often overlooked topic. My name is Dr. Midori, and I'm thrilled to see so many of you joining us tonight. I see folks are kind of trickling in. We want tonight's chat to be interactive, and so please use the chat feature. I will try to monitor it as best as possible. So the menopause transition, while a natural and universal process, can introduce a myriad of changes and challenges in a woman's body. One of the most significant and quite often the least talked about is the impact on vulvar and vaginal health. So tonight I'm delighted. I'm going to be joined by my colleague and co-host, Dr. Mashunga. She practices here in Franklin and Adams County with me, and she runs a very busy practice. So she's running a little bit behind and joining us tonight due to clinical activities, but she will hopefully be here shortly. Dr. Mashunga is a specialist in urogynecology and dedicates her practice to the nuanced intersection of urology, pelvic floor health, and gynecology. She provides care regarding pelvic floor disorders, incontinence, and the often overlooked health concerns surrounding menopause. Dr. Mashunga's urogynecology expertise is a unique lens through which she approaches the vulvar vaginal health. So today we will journey together through the intricacies of vulvar vaginal anatomy and menopausal changes, including genitourinary syndrome of menopause, and explore different ways that we can manage these symptoms. These are going to include things like hormonal options, non-hormonal treatments, and then we aim to demystify the pros and cons of each and answer all of your questions. In addition to traditional treatments, we'll dive into some of the more controversial, newer treatments where there's a lot of buzz, particularly rejuvenation procedures. So today's session aims to empower you with knowledge and options so you can make informed decisions about your health. Throughout this chat, like I said, please drop your questions and comments and share your thoughts. So, all right, before we get started with our discussion tonight, we thought we'd lighten the mood with a little bit of an icebreaker. You might have wondered why we dubbed this chat Hobby Hoo Ha. It's because there are so many creative, endearing, quirky names that are out there for the vulva and the vagina. So my challenge to you is let's fill our chat with all of the colorful array of euphemisms that we have for the vulvar and vaginal region. This is an anonymous exercise, so feel free to share your favorite names without any reservations whatsoever, and that'll give a few extra folks some more time to join us. So once we get that going in the chat, I'll read them off shortly. One of the attendees said there's no chat feature, but I was able to see your comment. So I should say in the Q&A box. I apologize. Somebody typed flower. My pink lady. The nether region. Sugar walls. That's a new one. I haven't heard that. I don't know about you, Dr. Mashunga. That sugar walls is new for me. Okay. So while nicknames like hoo-ha are wonderful and lighthearted, we really want to familiarize ourselves with the real terminology and the real anatomy. Okay. So first off, we're going to talk about the vagina. The vagina is the inner portion of that area, that nether region, and it's a fiber muscular tube that forms this beautiful bridge between the uterus and the vulva. So what about the vulva? The vulva is the exterior region. So we're talking about everything that spans from the mons pubis, which is right just under the pubic bone, all the way down to the outskirts of the anus. At the crossroads where the vulva and the vagina meet, we have this special area known as the vestibule or the opening. The vulva has several different parts. So there's the labia minora, or the inner lips of the vulva. These vary in size, and fun fact, about half of all women have labia minora that actually extend beyond the labia majora, and that's absolutely normal. The lips converge at the top of the area near the glands. That's that visible part of the clitoris. The glans is hidden under a little hood. That's the clitoral hood. And although it looks just like the size of a pea or a kidney bean, there's so much more than meets the eye. Just think of like the tip of an iceberg. The part we see is just this small piece of this much larger structure that's hidden beneath the surface. The clitoris is this really complex and fascinating organ. So beneath the surface of that small pea gland, there lies this almost wishbone type of structure that extends into the pelvic region. And that's where it relates to the urethra and that legendary G-spot, or in medical jargon, we really call that the clitorourethral complex. The clitoris kind of wraps around the urethra, creating this dense nerve network. So that elusive G-spot that people talk about, that was named after a German gynecologist, is believed to be located on the front wall of the vagina, about an inch or two in. It's not some sort of separate organ, but rather it's an area where the internal structure of the clitoris and the urethra meet and can be stimulated through the vaginal wall. So when we talk about the clitoris, we're talking about so much more than what's visible. Dr. Mashunga, is there anything else that you want to add about the vulvar vaginal anatomy? You're on mute.
No, I think you covered everything.
Okay. So now that we're all on the same page, we're going to delve into deeper discussion. So Dr. Mashunga, I have a question for you. What are some of the most common changes women experience in the vulvar vaginal region during menopause?
So the most common changes that women experience are associated oftentimes with vaginal atrophy, with the lack of estrogen in the vagina. And oftentimes it also involves just the atopic type of skin lesions like lichen sclerosis, where they have experienced itching and irritation in the vaginal area. And then unfortunately for patients who experience incontinence, I find that they'll have an incontinence-related dermatitis that's a result of just the wetness of just being incontinent and that contact of the urine with the vaginal walls or the external vaginal area.
Absolutely. You know, we have this lack of estrogen, this decreased blood flow, decreased collagen in the area. Sometimes, you know, even physically looking, the tissue can be a little bit pale. You can even see some small red spots at the vestibule or the opening, or even inside the vagina. Even the pH and the microbiome can change. Before menopause, it's primarily lactobacillus dominant, and sometimes as the pH changes a little bit, slightly, we can even see a shift in that flora and things that live in the vagina. And Dr. Mashunga was mentioning about the dermatitis or autoimmune conditions that people can get during the menopause. They can actually get these conditions, lichen sclerosis and lichen planus, at any time, but there does seem to be an increased incidence in the menopausal transition. Even though it's not the focus of this talk, today we're really focusing on vulval and vaginal stuff. Are there any changes into the bladder as well?
Yeah, so actually, surprisingly, a lot of people are always surprised to hear this, but the bladder and the urethral area does have, at least on the lower portion of the bladder, estrogen receptors. So unfortunately for some patients, I think that, you know, they'll experience some urgency, frequency, and some irritation in the area. But that just often correlates with patients also having, you know, worsening urgency and frequency sometimes when they reach menopausal area. But And unfortunately, I wish just treating with vaginal estrogen, I found that that can help with patients who really have milder symptoms. And I noticed that they also have signs of atrophy. But when patients start to get incontinent and have worsening symptoms, just using estrogen alone is not enough for those receptors to kick in and work better. But the bladder does have estrogen receptors.
Okay. So our main purpose of this talk tonight is to take a closer look at genitourinary syndrome of menopause. So we've kind of established some of the reasons why it happens. To recap, it's that decreased estrogen, decreased collagen, decreased elasticity. So the most common symptoms of genitourinary syndrome of menopause is vaginal dryness. Dr. Mashanga, what other types of symptoms should people look out for?
So in addition to vaginal dryness, there's irritation, pain or discomfort with intercourse. Some patients experience some bleeding due to the lack of estrogen and the dryness that they have in the vaginal area. Yeah, those are the main ones that I'm thinking off the top of my head.
Yeah, some of the other things that I know that some of the patients that I see often will complain of, and they often people don't think this is related to these menopausal changes. It'll feel like people will describe the sandpaper-like feeling in their vagina. Sometimes they'll even say, oh, I have this little itching, and they don't think that that's related to the menopausal changes. They'll notice just decreased lubrication during intercourse. I've even had patients, we talked a little bit about the bladder changes, but some of my patients will present saying they're having increased, urinary tract infections that they've never had at any other point in time during their lives. So,
well, to segue into that, I'm not sure if we're going to talk more about infections, but that is a good point because, well, I never associated GSM with infections, but with recurrent urinary tract infections, I tell most women that they peak with urinary tract infections in two portions of their lives. Before, I guess traditionally would say when one got married, but we know that's changed. Now it's more when you start having intercourse versus when you reach menopause. So the intercourse expectation with increase of urinary tract infections, a lot of women expect that, but they don't and are always surprised by the increase of infections that happen in menopause. And what I counsel patients and I remind them is that, the real estate between the rectum and the vagina is very short. And unfortunately, the source of the infections typically come from the rectal area. It is not related to cleanliness. It's nothing related to not wiping correctly. It's just that when you do have a bowel movement, just by nature, there is, bacteria that hangs around the perineal area. And what happens in menopause, unfortunately, is that lack of estrogen, that lack of blood flow, that lack of collagen, the lacks of the hills and valleys that exist in the vaginal wall make it easier for the bacteria to migrate and make their way to the bladder. So I use the analogy of driving down a highway in Nevada and it's sunny and you have a convertible car that you drop the top and you could go like 100 miles an hour and you don't feel it versus driving up one of the hills in Waynesboro. I know that area is hilly. It's a foggy day. You're going up a mountain. It's raining. It's harder to drive up that hill. So unfortunately, menopause is your Nevada right now. And what you need is the estrogen to create that mountainous, difficult environment to make it hard for the bacteria to make its way to the bladder. So that's what the estrogen does to the vaginal wall, make it harder for them to migrate there. And I have to remind patients that the reason why I'm prescribing the estrogen for you when you have UTIs, your urinary tract infections, is not because I want you, because of your sexual life aspect of things. It's to low down and reduce the number of infections that you experience.
Okay. Segueing or, piggybacking off of that, one of our attendees said, can recurring bacterial vaginosis be caused or exacerbated by menopause or perimenopause? And so absolutely, we've talked a little bit about the changes that can occur to the pH. Dr. Mashanga's kind of really highlighted almost introduction of more bacteria or a higher burden of bacteria that's not normally found in the vagina that is, can now easily, enter the vagina. those bacteria further change the pH of the bacteria, the pH of the vagina, and that almost allows other bacteria to grow, such as bacterial vaginosis. And they kind of grow to proportions where they're not supposed to, and that leads to infection and then sometimes symptoms. For those that are not familiar with bacterial vaginosis, the common symptoms that are associated with it are discharge or changes in the vaginal odor. Some people can have irritation or itching associated with it as well. Great question. So keep those questions coming. So with all of these changes to the vulvar vaginal skin, the vulva and the vagina, they're more apt to be dry. This means that there's going to be this increased risk of trauma. The trauma sometimes kicks off this cycle of irritation and inflammation. So before we get into some of the treatment options and how they work, we wanted to just really talk about just good vulvar care, because it's something that's not always talked about. The feminine hygiene or the hygiene, vulvar vaginal hygiene industry, there's a lot of different products that are available, and not all of them are great for the vulva and the vagina. So avoiding harsh soaps is key. The skin is this living landscape, and it's balance. Harsh soaps can upset the balance and damage the microscopic substances on the skin, raise the vaginal pH, and leave you feeling really dry. So choosing an unscented, mild cleanser is best. I recommend steering completely clear of wipes. I don't know about what you recommend, Dr. Mashunga. A lot of the wipes, I know, are patients that suffer from incontinence. Many of the wipes are packed in the, along with you in your purse, or you carry them because they seem to be very helpful. But some of the unnecessary irritants that are in the wipes are often culprits behind vulvar vaginal irritation and dermatitis. So yes, they're convenient for on the go, but you might want to consider other cleansing products. This is one I really want you to weigh in on this, Dr. Bashunga. So choose the right pads. So for incontinence, sometimes during the menopausal transition, especially in the postmenopausal phase, incontinence occurs. People experience leaking of urine. I always recommend using an incontinence pad over a menstrual pad. A lot of people use menstrual pads, but menstrual pads cannot handle all of that urine. And so that's going to leave this damp pad up against your skin, and you get irritation and potential breakdown. I don't know what your thoughts are on that.
I definitely do encourage using the incontinence pad for the same reason. They're designed to be able to absorb and let the urine sit in there differently as they would if it were a menstrual cycle. And unfortunately, I'm not sure because I haven't looked in the store, but I'm getting the sense that menstrual pads are probably cheaper than the incontinence pads, because the biggest complaint I get from patients is certainly the cost. But some insurances do allow for you to be able to get those pads through your insurance if you have the diagnosis of incontinence. So that's something to keep in mind that patients sometimes forget, and certainly using any health accounts that you have, like an HSA, or I know the other one starts with an F. Those kinds of accounts can go towards incontinence pads, especially if you've been diagnosed and there's documentation of that. So certainly seeking those pads is important. And of course, if you're incontinent, the importance of a barrier cream. I remind patients of if they have children or grandchildren that they're taking care of, like, some patients or some kids are sensitive to urine. It's the same thing. Just every time you go to the bathroom, just apply a barrier. It could be Vaseline, it could be A&D ointment, it could be, any one of the creams that you use it for a diaper rash. Golden something, the gold one. I can't believe I'm forgetting because my kids don't have diaper rashes anymore. But those are the products that I encourage patients to use just to carry around with them in their purse and just put it on there.
Absolutely. The other tip that I often share is moisturizing regularly. So if our facial skin was dry, we would moisturize it. Dryness in your skin is the skin's nemesis. So you want to keep the skin happy. You want to use natural moisturizers. There are products that you can purchase that are sometimes very expensive, but even natural moisturizers like coconut oil, olive oil, the
Mhm.
specialized products, they're going to be pricier, and they may not have tons of added benefits. Always avoid unnecessary additives and scents. I don't know if you have any go-to moisturizers that you recommend, but those are the ones I often tell people.
Well, no, I would agree with you. And actually, you're the one who taught me about the suppositories making them on their own. And I found that very useful. You know, Dr. Odori can expand on this, but having patients make their own suppositories by just getting some oil and freezing it, and then allowing for that placement in the vagina so you can have that continued lubrication. Because oftentimes some patients are very sensitive to the ones that you can buy over the counter. And I tell patients the way you treat your mouth and your lips, you know, if your mouth is dry or your lips are dry, you apply chapstick or you drink water. It's the same thing. You know, unfortunately with your vagina, you may not notice it as much, but you know, certainly keeping that area moisturized is important. There's Replens that you can get over the counter. There's another one called Reverie, which is sold through a company. And then I tell patients to use oil. I said anything that you can eat. So if it's olive oil, vegetable oil, coconut oil, that is not scented, because you wouldn't eat lavender scented coconut oil. That wouldn't be something that you would ingest. I tell patients that's the same thing that you can use in your vagina as well as using it during intercourse. It'll mess up your sheets. Just lay a towel down and, have your date night and call it a day.
Absolutely. Absolutely. The oil-based lubricants are definitely great for lubricant. Another tip, always pick the right lubricant for sex. There's water-based lubricants, there's silicone-based lubricants. Lubricant is a very personal thing, and the choice is yours. But for dealing with genital urinary syndrome of menopause, if, say somebody's moisturized and they have been using their coconut oil and they need a little bit more slip, if you will, during intercourse, I often recommend silicone-based lubricants. There's some that even have like silicone with vitamin E. Like I said, keep it simple. You don't want things with a whole bunch of additives that you cannot say that pronounce the names of. That's likely not going to be great for the inside of your vagina for sure. One question that we had is, how would hair removal impact vaginal vulvar health? Some people really hate having hair in that area. This is controversial, but believe it or not, pubic hair actually creates a moisture trap for the vulva. So removing it through methods like waxing or shaving, you're damaging the top skin layer and you're increasing your vulvar vulnerability, believe it or not. I know that's not, sometimes people remove hair for cosmetic reasons or to decrease, you almost think decreasing moisture if there's less sweat down there, but believe it or not, the pubic hair has a purpose. Do you have any thoughts on that, Dr. Mashunga?
No, I would agree. That is the purpose. I mean, the hair follicle does secrete some oils and keeps the skin moisturized. But, for those patients who prefer to have less hair, I also remind them to moisturize their vaginal area. Like I think oftentimes when people shower, if you don't moisturize afterwards, they might forget the pubic area and it's still part of your skin. So, being aware of it, using maybe shower gels that are moisturizing. So when you shower, at least your skin's getting moisture, because the reality of it is as we age, moisturizing and lubricating is definitely important. And just to remember that area also is a part of your skin.
For sure, for sure. Another one that people don't think of is stop smoking. I mean, we all know that smoking has so many negative effects on our health, but smoking actually has anti-estrogenic effects, meaning it further decreases your estrogen levels. It impairs your blood flow to all skin, not just the vulvar skin. And so, the vulvar and the vaginal area is extremely delicate. So, decreasing the blood flow, decreasing the estrogen, it's really not helpful, and you're not doing yourselves any favors, even in the vulva.
And just to remind those people who do smoke, in addition to it worsening your vulvar area, when it comes to the chain system of estrogen, if your body has access to estrogen, if you're still producing it, for instance, or if you're on hormone replacement, strangely enough, the vagina is actually the last man on the totem pole. I shouldn't have said man, but last woman on the totem pole to get the estrogen. Other organs have estrogen receptors and will grab it first before it reaches the vaginal area. So it's important to also keep that in mind. So if you're already smoking and if you have some form of estrogen, which you probably shouldn't have if you're smoking, but just keep in mind that already estrogen is the last organ to get it. It's worsened with the smoking as well.
For sure. So say someone has done their best to optimize their vulvar vaginal care, and they start to experience some of the symptoms that we talked about: vaginal dryness, irritation, pain with intercourse. We want to kind of just touch on some of the treatment options. Very early on in our discussion tonight, we jumped right into vaginal estrogen. Dr. Bashunga, do you want to expound upon vaginal estrogen, how it works a little bit, and how you tell your patients to use it?
Well, yes, I did describe briefly how it works when I was discussing recurrent UTIs. So, it's more so increasing secretions, working on the connective tissue. So what oftentimes patients don't realize is that the vagina is a muscle, it's a muscular tube. So unfortunately, what happens with the lack of estrogen, there's sort of a stiffening that might occur with it. So you want that elasticity, that connective tissue to come into the area. You want the blood flow. The blood flow helps with also, supplying the nerves or the necessary nutrients per se that it may need. So maybe it might heighten or return some sensitivity that might have been lost prior. And, as a result of the secretions and changing the pH of the vagina, it makes it an environment that's, less friendly to certain bacteria, so to speak. So it just increases the health of the vaginal area in usage. And using the cream for me is a preference. Like, you'll find that most of my patients, if they're candidates, will be on vaginal estrogen. I don't deal necessarily so much with hormone replacement therapy, but I like estrogen in the vagina for reasons of it directly going into the vagina, so it's localized. And a lot of patients worry about having systemic, meaning levels of estrogen in their blood, because that obviously is associated more with the risks that we worry about with estrogen, such as, increased thickness of the blood, so that can cause heart attacks, strokes, blood clots, and the risks associated also with breast and uterine cancer. But when you're using a vaginal source, it's localized. So there've been studies where they've taken the blood of women that are using vaginal estrogen, and the levels of the estrogen are almost minimal to non-existent. So my go-to is estradiol. Between that and Premarin, I use more estradiol now because it's generic in comparison to Premarin, but I can prescribe Premarin to patients if their insurance covers it better. I am not a fan of the estrogen ring or Vagifem, because I find that by the time my patients come to me, there are lower doses of estrogen, and I find that they don't respond as well. So I can't even remember the last time I prescribed any of those. And especially if they have recurrent UTIs, if that's what they're on, I take them off because I don't think it's enough estrogen to help them. For those ladies who respond, that's great. They probably do respond to lower doses of estrogen, but I prescribe estradiol 1 gram. When I initially have you use it, I have you use it every night for 2 weeks as a loading dose. And then I have you use it 3 times a week. So I'm a quote unquote a little bit more aggressive with my vaginal estrogen, because I know oftentimes the generalist will prescribe it twice a week. And then Premarin is prescribed as twice a week. So I don't change that much, but I don't prescribe Premarin a lot. And the reason why I don't prescribe Premarin a lot is because Premarin, in my experience, has a base that has an alcohol base. So by the time patients come to me and their vaginal area is dry and irritated, to add alcohol, it's almost like adding, when you have an open wound and you throw like salt on it. So I find that, a lot of my patients will complain of burning with Premarin. And some patients will even complain with burning with estrace. And then that's when I decide to use a compounded cream, and I use a compounded estrogen, and I try to have it have a glycerin base or an oil base, because that's, allows for the patients to kind of get into the estrogen, get their skin to be, essentially thicker, tougher, and more tolerable of buying the commercial estrogen. So even though it sometimes for some patients from a cost perspective, the compounded where the pharmacy makes or tailors that estrogen to you, I'll ask them, just stick with me, use it for 3 months, and then we'll switch back to what your insurance covers, because that by then they'll be able to tolerate, that little base of alcohol that might exist in some of because it's over the counter. So it has to have a shelf life, and they use that as a preservative, and some patients can't tolerate that.
You're touching on a very good point that I want to call out. Dr. Mashanga tends to see some of the much more severe cases of genital urinary syndrome of menopause. And really, there are interventions that you can do much early on to prevent some of the severe symptoms and the severe effects that we've been describing tonight. So although she doesn't use some of the other things that are in the toolkit, like the ring or the Vagifem, I offer all of those treatment options, especially when the symptoms are mild or they're in the early stages. They can be very effective at preventing progression. But once it's already, you've lost all of your rugae, you start to get a lot of thinning, the tissue starts to tear, you're in a situation where things have gone on for a very long time in order for them to get that. So early intervention truly is best at maintaining the health of the tissue. Another product which I use, and I don't know if you use that at all, is vaginal DHEA. This is going to act locally in the vagina, and it does tend to improve symptoms of GSM, particularly dryness, itching, burning, but it's specifically marketed for pain during intercourse. For women that experience pain during intercourse, it's supposed to be very helpful for that. And I've had good results with that as well.
And that's a great point. With that, I do not use it often, but when I do use it, it's typically for my patients that are not able to use vaginal estrogen for other medical reasons. But even my patients with history of breast cancer, oftentimes, I'll contact the oncologist or have the patient contact the oncologist, because even though I know obviously they have a history of breast cancer, and they remember, all they remember is like, stay away from estrogen. Sometimes they're far out enough, or maybe the type of breast cancer they have can still allow for it. So, and even within the community of oncologists, they are they're changing their thought processes and recommendations when it comes to vaginal estrogen. Of course, with patients that have that history, I do not prescribe it without getting permission from their oncologist. But oftentimes patients will say to me, I have breast cancer, can I use estrogen? And I say, well, we'll contact your oncologist. And oftentimes I get more oncologists agreeing to that than not.
Absolutely. I think the old school of thought where, vaginal estrogen, or all estrogen, if you will, was unsafe, is really going by the wayside because of the research that you highlighted, and that you're not getting high systemic or blood levels the way people thought previously. One scary thing for patients is that when they do pick up the prescriptions for these medications, some of those warnings about blood clot, stroke, cancer are on the label, but that information is being plastered on that for all types of estrogen.
Correct.
Yeah, and including, oral estrogen, it's not the same. It really, really is not the same.
Yes, I always joke with my patients when I prescribe it to them. I say, when you get home, don't try to think Dr. Mashanga is trying to kill you now. I'm always like, I talk to them about the risk and we go over it. So that way, at least they're reassured. And, and I actually appreciate patients who read the insert. That I think that's amazing. That's a great way of advocating for yourself. So I'm always very encouraging and impressed when patients do that.
Absolutely. Another thing I encounter sometimes is that my patients will be on systemic hormone replacement therapy. So they'll be, on oral, or they'll be on an estrogen patch. And sometimes the thought is that that's enough for the vulva and the vagina. And it's not. 50% of the time, systemic estrogen is not necessarily enough. You do need that localized treatment, and it's often that people need both.
Yes, and that piggies back off how the vagina is the last woman on the totem pole to get the estrogen, because all the other organs, your skin, this or that, your liver, everybody grabs that estrogen before it gets to the vagina. So it's what we call an end organ, meaning it's the last one to get it. So that's why it's important to also explain to patients that using that localized estrogen is important too.
So now we're going to delve a little bit into some of the controversial topics. Sometimes there's a lot of direct to consumer marketing about these topics, such as vaginal rejuvenation procedures. So I'll just want to define vaginal rejuvenation is a term that covers several different procedures aimed at either improving the aesthetic or functional aspects of the vulva and the vagina. They can range from surgical procedures like vaginoplasty, labiaplasty, to non-surgical things like radiofrequency and laser treatments. It's so important to consider both the benefits and the risks of these procedures. I have seen ads, particularly on social media, with so many claims and improves sexual satisfaction, increased confidence, reduced discomfort, fixing incontinence, and improving elasticity. Dr. Bashanga, what are your thoughts on some of these procedures?
I myself have not performed them. And I think that's more so with the settings and where I work. Certainly there are practices, and I have colleagues that utilize these tools. And I think that for some patients, there is some benefit to it. Now, in terms of how long it lasts, that part I cannot speak to, but I certainly think that at least when it comes to the lasers and the radio frequency, and the theory behind these products is that they do tend to increase the blood flow and increase the sensations, because it stimulates the blood vessels that come in, and but I think there's, like, when they're used around the urethra, maybe it increases that collagen and it can help with stress incontinence. But I think this may be true for patients with really milder symptoms. But you can get that same benefit from using estrogen cream. So I think the expense that to use some of these products, it may not, I definitely would say, if all things are exhausted that we can offer you in the office, using it safely in a way that, and with someone who's very familiar with the product is worth a shot. But, from my perspective, I feel as though we can offer those same things, at least in terms of the laser, by just using something like vaginal estrogen. Now, in terms of the labiaplasties and the vaginoplasties, those procedures are completely for aesthetic purposes. That's almost saying, like, there's, when it comes to, augmentative surgeries, there's the augmentation of a patient who had a radical mastectomy and just for that reason wants to go ahead and, get the augmentation there. There's a different thought process behind that, which is why it's covered by insurance. But if you are just like, oh, I breastfed my kids, I don't look the way I looked when I was, 25, that's what the labiaplasty is. There's no medical, well, there are medical reasons to have it. For instance, if you have, very enlarged labia that are causing discomfort, that are rubbing against your jeans, that are not allowing for you to walk. For young girls, they're not letting them do sports because of the discomfort and the pain. Yes, there are medical reasons to reduce them. And of course, you do it in a way that's aesthetically correct, where you restore the anatomy. But for other reasons, for the, other than that, or if you have, a blockage of the vagina. Okay, there are medical reasons to do some of these procedures, but for the most part, what they're advertising, what you're talking about, is for aesthetics. So, mentioning the anatomy of having your labia minora being larger But your majora, yes, that is very true. And unfortunately, as soon as we age, that loss of elasticity does affect your labia. So they may protrude a little bit more than they did when you were younger. So of course, if that is causing you some, issues and it's bothersome and this is a part of your body that you want to change, I'm personally not against for the patients who make the right decision to do any kind of augmentation, but it's not a medical necessity in those instances. So, I don't comment and I don't share with my patients, the size of their labia unless the complaint is that my labia is rubbing against my skin. And then we talk about it and I measure them. There's certain centimeters that are considered enlarged and we take it from there.
Yeah, I think that it's always, I just say buyer beware. And it's really a detailed conversation that you should have with your gynecologist about the symptoms that you're experiencing, because I've also had some of my patients experience distress after these procedures, either because they experienced a complication. Like any surgical procedure, you can have a complication where there's infection, there's bleeding, there's scarring. But some people are just disappointed. It costs a lot of money. It's not covered by insurance typically, unfortunately, especially if it's a solely cosmetic procedure that's not necessarily considered medically necessary, and if you're experiencing unsatisfactory results. So I would just say this is something that you definitely need a detailed conversation and assessment and kind of balancing the risks and benefits for each individual person. On the other side, I have seen some areas like Dr. Mashanga described where we have really exhausted a lot of our options and people have experienced benefit from it. One of the questions that came in the chat are all vaginal creams by prescription only, or is there some that are over the counter?
That's a good question. No, I mean, so the lubricants are over the counter. Like I mentioned, Reverie. And, I only mentioned that because it's a suppository and it comes in, and for some patients, they don't like to use the applicators and you slide it in, but it's, you could make your own suppository by freezing coconut oil. But the creams that are prescriptions would probably be the DHA, the vaginal estrogen, at least for that purpose. And then obviously if you have an infection, those medications are medications, but everything else for the most part is over the counter, correct?
Yeah. And I've seen some products on the market that are touting, actually, I haven't seen them with estrogen. I've seen them with progesterone in them. And there's not a lot of data about significant benefits of vaginal progesterone for the purposes of these sort of menopausal symptoms. So I have seen that in certain products. Some over-the-counter products, and this is where we get into the buyer beware. There are products that have THC or even cannabinoids in them that are either vaginal moisturizers or vaginal lubricants. They tend to be very expensive, and the data is still, not really clear in support of those particular products. So I hope that answers your questions. But most of the estrogen products or the DHEA products, you'll need a prescription, even if you're getting a traditional pharmaceutical grade or you're getting it compounded at a compounding pharmacy. So another topic that I know that the urogynecology space uses a lot is physical therapy. So what are some of your thoughts about physical therapy for the purposes of vulval vaginal health?
I truly wish that all women, especially after you've had a child, should undergo physical therapy just after childbirth in general. I find that, there's so many aspects of our body that are related to our pelvic area that you learn and should understand from that. And I myself, even as a urogynecologist, in terms of our training, yes, we know to prescribe it, and that's usually our first go-to with most of the things that we treat. But at least in my own personal training, I didn't do extensive training on pelvic floor therapy, but I was a patient myself, and I was amazed at how much you learned. I mean, I've had patients give me feedback on how it goes well, but the therapists really take the time to go through your habits, go through what you use, what you do. And, essentially they examine you, they assess, your core, in addition to assessing your pelvic area. Even watching how you bend over, how you walk has an impact on your pelvic health and musculature. And, addressing and identifying, areas that, in terms of teaching you how to increase your pelvic tone. That's something that we lose as we age, especially after childbearing. And being able to, I am fascinated by the number of patients that are not able to Kegel correctly.
Mhm.
And, I've seen so many versions of a Kegel that, it truly is something that I don't think, I couldn't teach it in the amount of time that I have in the office. That's the issue. It's not as though I wouldn't be able to do it, but I just don't have the space in my schedule to be able to do that. And that's what the physical therapists are able to do. So I tell my patients, just like how if you said, oh, I want to build my biceps, you want to build those muscles in your pelvic floor. And it involves engaging your core. It involves your correct posture. It involves sitting correctly. It involves being able to recruit those muscles and recruit them correctly. And no, it's not about recruiting them and stopping your urine. That is incorrect. That is actually more harmful than good. Yes, the muscles that are involved in the action of stopping your urine are involved, but I do not encourage anyone to do that. So as you can tell, I'm a great proponent of pelvic floor therapy. There's so many aspects and symptoms that patients experience between incontinence that can help, pain with intercourse where it can help. It can help with just, um, in terms of fecal issues and being able to defecate correctly. The act of defecating for some patients, sometimes you have to think about doing it. There's muscles that you can relax in order to allow for that action to occur. And there's some patients who have what we call high pelvic tone, where their muscles are the opposite of, they're not too relaxed, they're too toned. Just like how you have a knot in your neck, some patients have knots in their pelvic area, and it can cause pain and discomfort with intercourse. It can cause you having difficulty emptying your bladder. It can cause you to have difficulty emptying your bowels. And, the pelvic floor muscles are a basket. And at the bottom of the basket, in the front, there's the bladder where you empty, there's your vagina, and the back of the basket is your rectum. But they're all interconnected, they're all woven in together. And so many aspects of your pelvic health are so closely related that I truly feel like pelvic floor therapy is it's never too late for it. That's my opinion.
Absolutely. Absolutely. I definitely think it's a treatment option that is really underutilized, and a lot of people should consider it more for sure. So I'm just checking our comment box here. So I'm just going to read this comment out. It says, not a question, but a comment. I really appreciate a lot of the information shared tonight. I just wish I would have learned about many of these things a long time ago. 10 years in the menopause journey, it's probably a lot that's happened that's too late. But however, I have a daughter who is a young adult and plan to share the information with her so she can be aware for the future. Absolutely. This topic is not usually talked about a lot. We don't get into this deep dive or nitty gritty. And honestly, there's some of the things that we went over that we just touched the surface. Like going into the anatomy of the pelvis is far more deep and complex than what we went over tonight. So I think we need to have more of these conversations and normalize talking about our vulva and our vagina. Not to jokingly, we call this the happy hoo-ha talk, but it's really about our vulvar and vaginal health, and talking about it and naming it and talking about our clitoris and these structures is so, so important. And I'm so grateful for all of the attendees here tonight who joined us to kind of explore this. I just want to let you guys know that to explore this topic, you don't need a specialist that like Dr. Mashunga. You can really start these conversations with your gynecologist. They're trained and they're ready to guide you through these changes and these discussions. For those of you that are looking for a provider at WellSpan Health, we have gynecology providers who are accepting new patients in all of the counties that we serve. We're here to support you during this journey. And I would say that it is never too late. You know, I know that a lot of this information, it may be new to some of you, but there are always interventions that we can do, and it truly, truly is never too late. So I would like to, open it up. We'd love to hear from you. Some of you have shared some great questions and some great comments. But if you have any questions, please feel free to jump in and put them in the chat, and Dr. Mashunga and I are happy to answer your questions. The slide that's up is related to our midlife health providers. These are specialists throughout WellSpan who have additional certification by the Menopause Society, specializing in menopausal issues. And represented on the slide, we have providers in all regions where WellSpan sees patients. So I'm just checking the chat to see if we have any questions. All right, so I'm not seeing any questions. If you think of questions afterwards, you can feel free to let Tammy know. You have her contact information, and she can always get those questions to myself or Dr. Mashunga. So we're kind of coming up on the end of our time together, and I want to express my sincere gratitude to my brilliant co-host, Dr. Mashunga. Your experts and insights and candid explanations have shed light on so much about this important topic, and I can't thank you enough for sharing your wealth of knowledge with us tonight. Equally important, I extend a heartfelt thanks to each of you for joining us tonight. And thank you for your active participation and just your desire to learn more about your vulvar vaginal health. So we'll hang on for a few minutes, but we just thank everybody for joining us tonight, and everyone have a great night.
Yes, thank you very much. And I appreciate your time and attention. And thank you for inviting me, Dr. Adori.
Thank you, Dr. Mashunga.